So we're hoping to provide a kind of an overview, a masterclass of sorts on thumb-based arthritis. We're going to keep it hopefully very relevant, very clinical based as well. Cover all the aspects from kind of pre-surgical therapy, where Fiona comes in as very valuable, as well as post-surgical, as Rags mentioned, being very critical. And we're going to talk about all the different elements.
Yeah.
So over to Shari, my dear, kind of good friend and colleague. We'll begin the presentation.
Yep. Thank you, Honor. So as Honor mentioned, we'll go through some things in specific. So we'll start with joint protection, non-surgical treatment. We'll go through arthroscopy, some of the new implants, and post-surgical hand therapy. Now, we've chosen to talk about first CMCJ or base of thumb arthritis because it's something that's quite important, and I think all three of us see a lot of patients who struggle with it. So can't see any slides.
We'll just get that corrected for you.
Just get that corrected, but while the slides are coming up, CMC arthritis at the base of the thumb is something that's very prevalent in the community. Can you guys see the slides now? All right, perfect. So it's the second most common site of arthritis in the hand. At the age of 50s and 60s, you get it in about 11% of men and 33% of women. And as patients get older, you start seeing more. So it's 25% of men and 40% of women. And that roughly fits in with what we see in clinic on a day-to-day basis. So I'll quickly go through a bit of the simple anatomy and biomechanics. It consists of 4 articulations. So that basically means that the trapezium has a contact with 4 different other bones. So you've got the trapezium with the base of the first metacarpal, trapezium with part of the second index metacarpal, the trapezium with the trapezoid, and the trapezium with the scaphoid. So all of those surfaces can become arthritic, and all of that can cause pain. It's a very important joint because if you just take away your thumb and try and do things, you'll realize that you can't do all the simple things you take granted for, picking things up, doing up your buttons, activities of daily living. It's a biconcave saddle joint, so if you look at it, that's what gives it a lot of movement, but also makes it a bit unstable. You've got quite a lot of ligaments attached to it, and the anterior oblique ligament is probably the most important ligament, although some people dispute that fact. So all the ligaments are rather important. Now, what's important to know is that the joint force through the CMC is about 13 times your pinch force. And a normal pinch force is probably about, 8 kilograms on average for a middle-aged person. So you can imagine the force going through that joint is, in the 120 kilogram sort of mark. So that's a lot of force going through from just pinching. So you need that joint to be working in good order. So how do people present? They always come and say they've got pain at the base of the thumb, or sometimes even pain at their wrist. So you actually need to assess it well to see exactly what's going on. There's a lot of structures on the radial side of the wrist. So you need to work through and also take a bit of history to find out. It tends to radiate up the thumb and down the radial side into the forearm sometimes. They can present with concomitant carpal tunnel syndrome, and patients often think it's the same thing, but you need to be able to tell them you've got 2 separate things going on. They always say they've got difficulty in pinching, grasping, twisting movements. They find it difficult to hold things, they drop things. And as soon as you ask them, what about opening jars and door handles? They'll all say that they can't do it. They have to work around it with a different sort of grip. They can present after trauma. I see a lot of patients in my virtual fracture clinic presented from A&E who presented as a query scaphoid fracture. But if you look at the x-rays, you'll see that they've got arthritis in the trapezial area. And they all fit the right age group as well, the 60s to 70s. And that could actually be the first presentation of the arthritis at the base of the thumb. So how do you examine? You look for swelling, you look for pain on palpation, so over the dorsal area, in the anatomical snuff box, over the volar area where the STTJ is. So that's the scaphotrapezoidal joint. There can be some crepitus movement. So if you just press down on the thumb, you start moving it around in circumduction, they will get pain and you can often feel some grinding. They'll have reduced opposition. You try and ask them to see how far they can get to their little finger, and they often can't touch the base of the little finger, and you keep moving up and across the fingers. They'll have a reduced pinch and grip strength, hard to quantify sometimes because you need specific equipment, or also because they present with bilateral CMC arthritis, and there's pain on the grind test. And I think it's really important to try and differentiate it from dequervance tenosynovitis, which is tendon inflammation of your first extensor compartment, which is in the same area. And there's some specific tests you can do for that. The test I find that's really useful to differentiate between dequervance and first CMC arthritis is known as the wrist hyperflexion thumb abduction test. If you hyperflex the wrist and you ask them to push up the thumb against pressure, those with dequervance can't do that because you're actually stressing the tendon. But if they've got arthritis at the base, they'll still be able to do that. So that's quite a good way to differentiate between the two. And late findings, they can come with multiple deformities. The thumb gets abducted into the palm, and they get a Z deformity because of hyperextension at the MCPJ. So imaging, we always start with x-rays. They're very useful. I tend to request a PA, a lateral, and this view, which is a peritrapezial view, which has been described really well in the literature, and it's really very useful. You get a really good view of the trapezium. You can see the first CMCJ, and you can see the STTJ really well. Most radiographers know how to do it. CT scan, not often. I've done it once or twice because the trapezium had actually subluxed volarly because all the ligaments had come away and it looked like the patient had a trapezectomy done before, but the trapezium had just moved. So that can be useful on occasion. Standard classification, we use Eaton and Littler. Classification mainly helps us with our treatment options. Stage 1 is when they come with pain, but all you see in the x-ray is widening of the joint space, actually. That's because of the swelling, inflammation, and synovitis. Stage 2, when you get the narrowing of the CMC joint with a few osteophytes and some mild sclerosis. Stage 3, when you have significant narrowing with more osteophytes measuring more than 2 millimeters. And stage 4 is pantrapezial, which means you've got arthritis all around the trapezium in all the 4 articulations. So in terms of management, we'll go with non-operative and operative management. We'll talk about corticosteroids, joint protection, analgesics. These are all what we should always start treatment with. And then we'll talk about the different operative treatments. All right, I'm going to hand it over to Fiona now.
Thank you.
Just press it down.
Great, so thanks for having me. I'm going to be going through some of the examples of what the most recent research shows for managing this condition conservatively. Sorry.
We've lost the slides. Try that. This one. Not. Oh, there we go.
Thank you. So the first biggest thing is education. And the most identified priority is actually that we should be supporting and providing the resources for self-management. So the first thing I generally do is educate the patients on what osteoarthritis is, and we generally want to try and stay away from the words such as wear and tear because of the fact. Because of the fact it causes a negative impact on how a patient might perceive what OA is. So they might become a bit more fearful of moving, they might be worried about what exercises are actually going to do to their joint. So the idea is that we want to promote their confidence and that actually they can manage these symptoms, especially at an earlier stage. I do usually go through the different treatment options, such as pharmacological or surgical. And I always advise them that actually the education, the exercises that I do show them are things that they should continue throughout, even when they get these other options done to maximise the treatment effects. Obviously, the thumb and the CMC joint, as we know, we use it in almost everyday function, so it has to withstand a lot of force. I advise them that actually it's not going to be a quick fix. It's something that's going to take time. So when they do come to see me, I often say give it about 3 months of the conservative management, and then at least it will give them a chance to change their habits and build a routine to do exercises. So looking at resources then, so the first thing is being able to provide written information. A website that's pretty good is the Versus Arthritis. There's lots of resources on there. There's a helpline for patients. It talks them through different diets. It goes through the different professionals that they could actually go and see. The next bit is I talk to them about positive behavioural change, which are the 4 Ps, which are problem solving, planning, prioritisation and pacing. I'll go through general exercises with them, so your cardiovascular exercise, global strengthening. Something else that some patients like is thermal or arthritic gloves. Now, there is limited evidence to how much these can actually help patients. However, they do provide compression, so a gentle support around the joint. They can provide warmth, especially during those cold weathers. They might complain that's when they get the most pain. And they can also provide an anti-slip surface to help with function. So I'd say it's very patient dependent. And then finally, I've just popped up there about topical anti-inflammatories. They can provide short-term relief, and if it is helping with the pain and swelling relief, then they can continue to do that. So the next part is joint protection. And this is about reducing that excessive load onto the joints. And to do this, we need to be modifying those activities. So it could be a case of advising them to use 2 hands instead of 1. They could be using different aids. They could be breaking up tasks into sort of smaller components. So I've popped down there just some websites that you might direct patients to. Most of them have like numbers on them if they can't get online access, or catalogues as well. So here I've just got some examples. So the first and the third picture show significant instabilities of the thumb, whereas you can see there the second and the fourth picture are at its most stable position. So the CMC joint is at its most stable position when people are gripping in that O or in that C, so that nice arched position. So it does mean that every time they're doing exercises or even in their everyday activities, we want to try and correct those deformities. The muscles obviously need to try and synchronise to maintain that stability. Otherwise, what they do is they start forming bad habits and they start pushing into these instabilities even more. And actually, that just increases the force on surrounding structures. Perfect. So I'm just going to go through the different types of exercise. So neuromuscular retraining is about redeveloping that normal and controlled movement pattern. It's about fine-tuning the ligaments with the muscle structures. Then I'll go on to strengthening. So working on the thenar muscles to work on the pinch, but also working on the first dorsal interosseous muscle, and this is known as the main stabilizer of the CMC joint. I'll then go into the third stage, which is then practicing all these sort of advice into their functional activities, making sure they're continuing using that arched support and also using assistive aids correctly. So I've just got an example of the type of home exercise program you might do. So just to begin with, general range of movement. You want to be getting that thumb into all planes of motion. A really simple one is just your general opposition onto each fingertip. If they do have some stiffness, they could do some passive stretches to reduce any contractures from the muscle, or if the joints are generally stiff, gently is absolutely fine. They're not going to do any harm. So I would go within sort of a pain tolerance. In the strengthening box, the first top left picture there is a really easy first dorsal interosseous strengthening exercise. So literally elastic band around the fingers, index finger abducts out to the side and back again. If they're putting a lot of strain in the thumb, they could use like a ball or something in that arch position, and again just abducting that index finger up and against any resistance. The next picture along is working on the thenar muscles. So I generally start with an isometric tip to tip pinch. It's a good way as well to check if there is any instabilities in the MCP joint. You can then progress that on into dynamics, so using like a sponge or a ball. The bottom one I've got there on the strengthening is a useful one for those who start to sublux at the MCP joint. And the idea is that they keep the tip of their IP joint in flexion and they pull the band up, and this just works on the extension of their MCP joint. The last pictures I've got there are the neuromuscular exercises. So the top one is tennis ball tracing. So literally their thumb just traces around the line of a tennis ball. It means that they stay in that nice arched position, and as they're moving the ball, their index finger, as it abducts out, it means that it's contracting that first dorsal interosseous as well. And the bottom one there is paper tearing or tissue tearing. So again, getting them into that nice opposed position. But they can start to learn that actually they don't need to pinch down so forcefully, and that's the point of these exercises, reducing that force and then simply tearing the paper. So the final slide I'm going to go into is about splinting. So splinting is something that generally it was a first treatment method. It's kind of a go-to often. I find it's very specific to a patient's needs. So some patients might say that actually it does help with pain, sometimes in function, sometimes in rest. Other people find that it just gets in the way. I've used it sometimes to just correct any deformities, and I've put there such as reducing any subluxation, maintaining that web space, and supporting the proximal, that base of the metacarpal. So there was a recent trial which basically was called the Otter 2 trial, and the conclusion was that there was no additional benefit of adding a thumb splint to a high quality evidence-based support self-management program for OA delivered by therapists. So the idea is that actually splints shouldn't be used as kind of a standalone treatment. They're a very passive treatment, and if patients wear them too much, they could actually weaken all those structures instead. I think if someone comes to me and they're unable to self-manage or they are in high levels of pain, it might be an initial consideration. So it's really clinic dependent. And I've just got some examples of the different splints down there. So the first one is a rigid push brace, which is a prefabricated one, which supports the base of that where the CMC joint is. The next one is a soft neoprene type. So again, mild support, allows full movement, nice compression around the joint. The third one is a custom made one, where again, I could come up at slightly higher dorsally, and actually it blocks that joint into that hyperextension. And the fourth one, is kinesiotaping, which again provides a really gentle support around the CMC joint, but also it provides a bit of proprioceptive feedback for the MCP joint, and actually it allows them to still use their hands, function and exercise. Thank you.
Great, thank you, Fiona. I think it's a really great series of slides just to remind us that actually how much value there is to therapy, to therapy beforehand. I mean, sometimes patients just are given splints, but actually there's a whole lot more. And you just examined that last slide, just a whole lot more.
No, I think so. I think the education bit is really important because, you know, there's so many different operations and so many different methods, but all of that's towards pain relief. And if you can do that without having to go down the surgical route, by just getting the education bit right, it really works wonders, because, you know, once you start going down the surgical route, you know, you can't go back.
Yeah. One thing to add is that, yes, there's post-traumatic arthritis that comes on, obviously, following trauma, whereby the ligaments are damaged or the cartilage is damaged, but actually most base of thumb arthritis comes on slowly over years, and it's due to the attenuation of the ligaments you spoke about, Sharia. And essentially what happens is that bicondylar joint slips out of position, and hence patients start getting pain. By starting that therapy program and by providing that stability at the base of the thumb, just realigns that joint. And hopefully,
and I think I slow it down, because when you have as Ono said, when you have the ligament instability and you lose that congruity of the joint, that's when it's got abnormal forces going through it, so it starts to wear a lot quicker. So if you can just get that part right from the start, the strength across all the ligaments in the correct position, then you can actually slow down the arthritis significantly.
Yeah, no, I agree. The next topic is injection therapies. I'm not going to labour this too much. I think it's well established. It's a very good, not quite a first line, but also an adjunct to the hand therapy programs. Yeah. Steroids are the most accessible. For example, Kenalog injections. I tend to recommend these, that you can perform them in the clinic under palpation guidance. Sometimes the joint is quite narrowed and the arthritis is a bit more advanced. It's sometimes better under ultrasound guidance. And what that does is provides ultrasound or image guidance. Yeah. And it provides some reassurance that you've injected in the right place. More and more popular now is platelet-rich plasma, or PRP, which you can see on the right of the slide. There has been a lot of evidence to support the use of PRP, although it's a little bit more difficult to access in the private sector. Actually, quite accessible on the NHS. Yeah. For example, at the Royal Free, we do recommend PRP for recalcitrant patients where Kenalog or steroid hasn't worked so well. And there's a lot of evidence to support the longevity of PRP injections as well. In between, there's hyaluronidase injections, which kind of have gone out of vogue, but maybe coming back into vogue as well. And there is evidence to support HA injections as well. But generally speaking, it's between corticosteroid, typically that lasts about 6 months. PRP lasts a little bit longer, up to about a year. So there's a balance to play. PRP is a little bit more cartilage protective as well.
Can I ask a question? Because I think this will be relevant to people. How many steroid injections would you give?
For me, if the first injection doesn't provide much benefit whatsoever, I stop there. Yeah. and then advance to the next step on the ladder. If it works really well and it lasts over a year, I would give that patient or re-offer that patient another injection.
I think so, because I get asked that question all the time. Yeah. How many injections can I have? Yeah. And also in the private sector, it's worth knowing that sometimes insurance companies don't support repeated steroid injections, so that's something to be aware of.
Bear in mind as well. Yes, if it works really well and patients are happy and they often want a further injection, I would be happy to offer them.
Same.
The second one or more. So moving on from that, so the next treatment option is thumb-based arthroscopy. Now it's not so widespread. Sharon and myself both provide this. As you saw from that slide a few slides ago, there was a ladder of different treatment options, and thumb-based arthroscopy comes in at the very early stages. So really you're looking at a stage 1 where there's synovitis, there's swelling of the joints. If you look at the x-ray, the joint actually looks distended, or at the most just slight arthritis there. What I tend to do personally is provide a debridement, a synovectomy, and a thermal capsular shrinkage, and we'll touch upon that in a second. So the aims of the procedure really are to remove that inflamed synovium, and that provides pain relief. You denervate the capsule by performing the capsular shrinkage, and again that provides pain relief. And then the key thing here is really to try and improve stability, to gain surgical stability in the joint by doing a capsular shrinkage and using a diathermy probe or a radio frequency ablator around the joint from the inside to shrink the capsule, and that introduces some stability. You can go further, you can remove osteophytes, and some people actually start removing part of the trapezium or the base of the metacarpal. But personally, I tend to keep it very simple. And Shara, I think you do
exactly the same thing. Exactly.
Yeah. So a little bit about thermocapsular shrinkage. Essentially, what it does, it initially by heating up the collagen fibers in the capsule and in the ligaments. What that does, initially the collagen fibers unravel and then they recoil at a much tighter, much more close-knit structure, and then that provides a stability. And also by doing the thermal ablation, you denervate the nerves as well. The downside of the arthroscopy is that you do have to immobilize the patient for 6 weeks because the joint becomes more lax around 2 to 3 weeks. and then becomes tighter around beyond that point. So you have to immobilize them for 6 weeks. MRI can be very useful just to pick up the very early stages. So I do tend to consider an MRI scan if I feel we are at that grade 1 stage and we may be considering a thumb arthroscopy. The portal is a simple procedure, can be done on the local anaesthetic. 2 small portals in the anatomical snuff box, just here, either side of the thumb tendons, the abductor pollicis longus and extensor pollicis brevis. The setup is simple as well. On a simple traction setup, a small camera to enter the joint, and you see structures such as these. This is a normal joint where you can actually identify the tendon, the FCR tendon there, anterior oblique ligament, the superficial and deep components of it. But essentially, you can see in a normal joint, you can actually see a lot of the ligaments that are stabilizing the joint. In a more inflamed joint, clearly the definition is lost, and you get more of a picture like this. As mentioned, you can go as far as removing osteophytes in the joint to minimize impingement, and that can help with pain control. So the post-operative regime, I tend to put the patient in a plaster for a couple of weeks, then over to Fiona or a hand therapist to immobilize for a further 4 weeks. And a thermoplastic splint works really well. Patients are quite happy with that. And then building up free range of motion and building up strength from that point onwards once the stability is regained. Now, with regards to the outcomes, quite broad. I have found that a third of patients have very good sustained relief. A third improve initially, but then there's early recurrence, and there's a third of patients don't feel much benefit whatsoever. Now, you could say the odds are not so good, but actually the procedure is so simple with very low risk that actually it is worth trying this at the very early stages when certain things haven't worked, such as the therapy or the injections.
Plus, you're preserving your own bone stock.
Correct.
You haven't gone down the route of taking off bone yet. Yes. So that's why even it's really worth trying, especially in those patients who are very young and present with very early symptoms.
The difficult class of patients, I think you'll agree in that they're in their 30s, 40s.
Yes.
And this doesn't burn any bridges.
No.
It doesn't burn any bridges. You're not removing or implanting any devices. Hence, you can go forward from that position. So some background evidence. As you can see, a variety of different outcomes, but generally, significant improvement from the literature, bearing in mind what I presented as a personal experience as well. So moving on from that, so then in my kind of treatment regime, there's then the Cartiva, synthetic cartilage implant. Now the Cartiva is a hydrogel polymer, a polyvinyl alcohol made of alcohol and saline. It's actually the same substance as contact lenses. It's been used in a big toe for hallux rigidus, so first big joint, first MTP joint, osteoarthritis. It's been used for many, many years. And I picked this up on fellowship from the Pulvertaft. They were running the initial studies on the Cartiva implant. And they've been doing it for over 5 years now. The implant is slightly smaller for the thumb, as one would imagine. And in my mind, it's a kind of joint preservation surgery. So I'll show you a little bit about what it looks like in the joint in a second. The implant itself has been shown to have very high very high biocompatibility, very good wear testing, and properties very similar to cartilage, which is great. The Pulvertaft did some initial studies and then presented their 1-year data, which looks something like this, where the findings compared to something like an LRTI, which is a trapezectomy plus a ligament or a tendon interposition into the joint, or a standard trapezectomy, they found that pain was reduced considerably more than those two procedures. Pinch strength improved considerably as well, tip pinch strength over 109% compared to pre-op, and grip strength up to 82%. So functionally, patients were improving a lot. From a functional outcome score, again, the scores dropped moderately, I would say, admittedly, from the data. So key questions in my mind before I started using this implant was, well, how long would this implant last? Most of the data really is out there from the use in the foot and ankle, and patients the implant was surviving about 85% survival rate over 5 years. Possible risk, some had persistent pain in a big toe. In my mind, there's probably more shear forces going through that area and a higher load. One case had an infection and the problems that they were seeing where they had to go on and advance the treatment modality was implant subsidence. There was one foreign body reaction, I believe. So an ideal patient is one which is probably beyond the grade 1, so into grade 2. Sometimes I push it into grade 3, refractory to conservative management, such as the injection and therapy programs. Patients must have good metacarpal bone stock, so you can't implant it in patients where there's bone cysts because the implant will subside, and hence a CT scan would be useful in that modality. You should avoid it if there's pain in the scaphotrapezial joint, so the joint just proximal, because the patient will naturally have ongoing pain. So this is a patient who's done really well and has had both sides operated on myself now. He's a 64-year-old male, right-hand dominant, is a carpenter. And he only had short-term relief from the injections. And he sought this out himself, so he wanted the Cartiva procedure. So we started on one side, and this is the approach is very much like a trapezectomy or a CMC joint replacement, which we'll see later. Essentially, you insert a guide wire or a pin. You create a tunnel for the implant and you insert the implant under pressure and it's deployed. Holds the joint slightly apart, so it resets the joint somewhat. Part of the procedure, you tighten up the joint capsule and provide the stability. So this is the patient. Michael, you might just have to click on that for me if you don't mind, that first one. So this is his, the first side, and this is him coming out of plaster a little while after, and it is a little bit tight. I was a little bit cautious at the beginning, but he was really keen to get going. And when we did his second side, he didn't want any protection whatsoever. So he just wanted to get going with some simple bandage, which removed after a couple of weeks, and he really started moving the joint. And the next slide is him after his second operation, just really keen, a few weeks after, really keen to get going. And you can see, because we didn't immobilize him, and that's what the Pulvertaft have done as well now, they initially were splinting patients, putting patients in plasters, but now they've moved off that and just mobilizing patients early on, strengthening the base of thumb, and Fiona's seen a few of the patients now, strengthening the base of the thumb, really getting the patients back moving. So they seem really happy, and this was several years ago, and I've discharged him. He is having outcome scores collected, so eventually, hopefully, once we've got a good number of patients, we'll be able to present those outcome scores as well, longer term. So that's the Cartiva implant, and I really like it. Simple, it doesn't burn any bridges, it works really well for grade 2. And then if we move on, I'll bypass this. So as mentioned, yeah, the advantage there, just on the previous slide, was that it's bone preserving, it maintains motion, and it doesn't burn any bridges, minimally invasive as we mentioned. And later on you could either remove the implant, go on to a trapezectomy, or my plan would be to convert to a joint arthroplasty. Yeah. And I'll hand over to Shari now to talk about joint placement.
I think one of the key themes you're going to see is about not burning any bridges, because a lot of these treatment options are fairly new over the last 5-6 years. We still have limited data on them. So that's why it's more important that we still have a backup plan and we haven't burnt any bridges. Now, total joint replacement is something that I really like. I mean, as an orthopedic surgeon, throughout our training, we've done so many different kinds of joint replacements, and this resembles a hip replacement, and a hip replacement is the joint replacement that works the best because it's a simple ball and socket joint. It's been tried and tested for many years, and it works really, really well. Now, the CMC joint replacement has actually been around for more than 20 years. The first version was a cemented version, and some of them have actually lasted 20, 30 years. I saw a patient recently who had one put in about 20 years ago, and she's had no issues whatsoever since. So they work, but they've gone in and out of fashion. And over the last, I would say, 6 to 9 years, they're regaining a lot of popularity. The Americans and the Europeans were doing them a lot more. We've caught on slightly later because of our reticence and because of some of the implants in the past didn't really work very well. So there was a version 2, which was, if you look at the image, the standard joint replacement, and the third one, which is we're into now, is a dual mobility. The difference between that is that there are 2 articulating surfaces in the dual mobility. So in theory, it reduces the wear between the cup and the trapezium, because you've got a head at the neck, and then that sits in another plastic ball before that plastic ball sits in the trapezium. So because there's two articulating surfaces, the amount of force going through into the trapezium is less. So there's less risk of that wearing out. So that's the whole idea. And also, by making that a bit bigger, for it to dislocate, it's a lot harder because it has to move a greater distance to actually dislocate. So in theory, from the engineering and the scientific point of view, it's very sound.
Dislocation rates have been negligible, really, since the introduction of the
dual mobility. Yes, I'm going to go into that. Dislocation rates have dropped since we've gone into the dual mobility. So initial studies, which are about 8 years now, probably show about 93% survival of the second generation implant, which is the standard. And the key things are all of the things that we do are garnered towards pain relief. But as opposed to a trapezectomy, what this does is it actually increases your strength and your range of movement. And that, I think, is key, because that's something that the patients miss a lot. Apart from the pain, which they want to get rid of, they get used to the fact that they can't use their thumb as much in terms of the mobility and power, but this actually restores it. It restores the length, and it can correct a lot of the deformities, and you can start movement earlier as well. I mean, some people, when they first started doing it, started moving at 6 weeks, then it got down to 4 weeks, and now I'm probably moving them at 2 weeks now, post-operatively, to get them going. So once the wound is healed, I get them going. As with the Cartiva, it's contraindicated when you have concomitant arthritis in the joint below, so between the scaphoid and the trapezium, because you're not restoring that joint. So again, important to clinically assess if the patient is actually tender in the STT. I find a lot of x-rays you think might be a bit dodgy, they might have a bit of arthritis, but clinically they've got no pain. And also in the horizon, they're coming up with implants that can tackle the STT as well. And potentially you could do both at the same time. Again, the French have started doing it. We're still awaiting some more data before we consider whether that's something we would do as well, replacing both joints at the same time.
Maybe we should touch on how to differentiate between CMC. You mentioned CMC arthritis, but then ST joint arthritis.
Yeah, so for me, the key thing is when patients present, they've got pain all around the base of the thumb. So on the dorsal side, if you just move your thumb down past the metacarpal into the groove in the anatomical snuff box, that's where your first CMC is, and that's when you get the first CMC pain. STT is much better on the volar side. So if you just slide your thumb forwards and go slightly further down, that's your STT. And if you're flexing your wrist and pressing it, that's when they're sore. So that's how you clinically differentiate whether or not they've got STT arthritis. That's what I find. And also in terms of moving it from ulnar deviation to radial deviation. So these are the few ways of differentiating between them. Is there anything else you know?
Yeah, I find that works really well. Radial ulnar deviation, what happens is the scaphoid flexes and extends. So scaphoid extends in ulnar deviation and flexes in radial deviation. So that typically assesses that joint. Yeah. And then, as you mentioned earlier on, the other associated findings for the CMC joint. Yeah.
So again, a bit of literature. This systematic review was published in 2021. They've looked at a lot of replacements, and again, the rates are pretty similar: 93% survivorship 5 years. Failure rates 9.8. Again, it differs on which implants were used, and a lot of that was due to surgical technique more than anything else. It's got a bit of a learning curve because it's not something that you're used to. Loosening rates very low, 2.4. Dislocation rates 4.4, but that's including the single mobility. We've had one UK surgeon in Oxford Street look at his 52 replacements over the last 4 years. And 96% of the implants have lasted. Failure rate was 5.7, loosening rate 3.8%, and dislocation rate 0. And that's what we're finding with the new implants. So this is a video of one of the first few patients I actually did a replacement for. So we can just press play. So pre-op, you can see she had sublux, and she had about grade 3 arthritis. Let's say STT was fine. That's what it looks like post-op. So it looks like a mini hip replacement. And at 6 weeks, she had full range of movement, no pain whatsoever, and the scar had healed, and she's delighted with it.
So the great thing is you're 6 weeks ahead of trapeziectomy. So trapeziectomy, you start mobilising at the 6 week stage. Patient's been in plaster. At least my practice 6 weeks.
Yeah.
Some people get them moving a bit earlier, but they're only just starting to move at that point, and they're stiff. There's risk of joint subluxation and so on as well. I mean, some patients you have to do it, and it's a gold standard procedure, and we'll touch upon it in a second. But the big advantage is that early range of
movement
and maintaining that grip strength.
Yeah, you get the grip strength is very good, and the data supports that, and the range of movement is also very good. A trapezectomy is a painful operation to get over.
It takes
about 3-4 months at least. I always tell my patients, but the first 3 months you're not going to be happy with me, but the pain will go away. But with this, it's much quicker.
They're happy.
So a couple of pictures. Again, the approach is the same for anything we do. So from the Cartiva to the CMC to the trapezectomy, it's all the same approach. You're basically going down to the joint. So you're cutting off about 5 millimeters, which means that when you do the Cartiva, you again haven't burnt any bridges because you haven't taken off that much bone from the metacarpal base. So you can easily convert this to this if you need to do. The equipment is small, but the equipment is quite nice actually with the implants that both owner and I use. I use the Maya implant. Dual mobility is really a very good implant with a long history. The key to it, the most important part is getting that wire into the I'll answer that question at the end of the slides, David. The key to it is getting the wire into the trapezium, into the center of the trapezium. You just need to spend time doing that. I always consent my patients for plus-minus trapezectomy, not that I have any doubt on my abilities, but because of the fact that sometimes you don't know how soft the bone is going to be when you go inside. So, David, your question is, if the trapezium breaks or if it fails, the salvage procedure is you can actually just convert it to a trapezectomy. In the acute setting on table, convert to a trapezectomy. In the future, if it fails, studies have shown that you can just take the trapezium out and leave the metacarpal stem in, and it doesn't cause any problems. It acts like a spacer, actually. So that's actually shown to work really well.
From experience, I've had one where I've had to revise. It was in there for about 13 years. The whole implant came out, such that there was a shell left of the metacarpal, but it was fine. Because you've removed a little bit of the base of the metacarpal, you do have to provide some stability, and you can create that by the tendons, associated tendons around the base of the thumb, anchoring them into the second metacarpal can provide that support. But yeah, it is a little bit of a fiddle to revise.
Yeah. So again, with anything, I think revision is always a bit of a problem when you're dealing with that, and that's why we've waited for the data to show that the revision rates are very low, and that at least we know we've got salvage options that we can do.
Correct.
We don't want to start taking on anything that we don't know how to salvage. So it is uncemented. If you looked at it, it's HA coated, so it's uncemented, no cement involved. The bone actually then bonds the HA coating around the implant. So as with many of the new design hip replacements.
Let's trigger that.
There's a bit of a video which shows on table already. Even before we tighten the capsule, you can see it's actually quite stable, and you've got a really good range of movement. We're moving it into extremes of movement, which you wouldn't normally do, and it's not dislocating.
So those movements were reflecting what the patient would be doing kind of afterwards, so kind of leaning through the palms, or kind of gripping onto something. So if it doesn't dislocate on table, and that's before the capsule's been closed, then it shouldn't dislocate afterwards.
Because you're providing more stability once you've done the capsular closure.
This is a patient of mine. She was about, I think, 2 weeks. So I would provide her a splint and then start motion and get her moving at this stage. You can see she's already comfortable. One thing to note, sometimes patients do regain function at the base of the thumb and start doing more, and they can get a little bit of a de Quervain's tenosynovitis. So something just to be aware of, managed in a normal way, but again, just to be aware of, there is some discomfort. It's often towards the de Quervain's extensor side. This patient had a prior, some years ago, an extensor tendon rupture, so she had a tendon transfer to the thumb. So hence she's got a little bit of functional deficit in that thumb already.
EPL tendon transfer.
EPL, yeah.
But yeah, 2 weeks, that's brilliant. You wouldn't be able to do that with a trapezectomy at 2 weeks. So
a couple more examples.
6 weeks.
A little bit, yeah. She reacted to the stitch. She used monochrome, but she just reacted to the stitch. But
yeah, but again,
comfortable.
really good. Look at that.
Excellent range of motion.
Yeah, perfect.
I think it was the same patient at 2 weeks. We can bypass that.
Right. So a bit about excision arthroplasty or trapezectomy, which is the gold standard that we've always considered. I mean, this it keeps moving back. No.
Maybe we'll let you take control.
We'll let you take control. It's getting slightly confused. But a trapezectomy has survived the test through time. It's one of the procedures that actually has been in our armorium as a hand surgeon, and it's one of the what we call our bread and butter sort of operations, what we've trained through. Mm-hmm. So we all know how to do it. We come out of training having done loads of them. They work. They just take a bit longer than some of the newer ones to work in terms of time. But they don't. What they don't do is actually restore. They don't actually restore your grip strength and your range of movement. Mm-hmm. So your range of movement and grip strength stays as it is. But at the end of a year, the pain relief is actually very, very good. And some of the studies show that it's very similar to any of the other options you have. There are many different ways of doing a trapezectomy. A simple trapezectomy just means removing the trapezium and doing nothing. Some people do a ligament reconstruction or a sling with a tendon. I've moved on to doing a tightrope at the base because that seems to work. It's just in my mind, by securing it, it decreases the chance of it subsiding into that space over time. Because sometimes I have seen patients 10, 15 years down the line who have had a bit of subsidence and come through, and I then have to go into a tightrope for them. So I think this is still a good option to have. If you've got pantrapezial osteoarthritis, this is still an option a lot of people tend to go towards. But like I said, I'm quite excited about some of the new implants. The same company that does the Maya implant for the first CMC have now come up with an implant for the scaphotrapezial joint as well. And that seems to be doing quite well. And again, we're collecting more data on how well they do if you do both operations at the same time. I've got one patient who wants both at the same time, actually. So we'll watch that space.
The last slide here, the last couple of slides from the surgical side is about CMC joint distraction. CMC joint distraction is really our colleagues, from my colleague's experience, Mr. Narani, and it reflects on what's been used for knee and ankle joint distraction. And what it does is it unloads the cartilage, gives the cartilage a chance to recover, to regenerate, reduces some of the inflammatory components present in the joint. Typically, one would use it for grade 2 or 3 osteoarthritis, and this is the little distraction device. You distract enough just to offload the cartilage, apply the external fixator for about 8 weeks. And what it does, it just enables, you can see from the x-rays, just enables some cartilage regeneration. So I haven't had a huge amount of experience myself, but my colleague has, and unfortunately the videos I've got in a second not quite presenting very well, but patients have been very happy. They tolerate the external fixator quite well. As you can see from this slide, outcomes, limited literature, but outcomes showing that there's been a considerable reduction in the visual analog pain scores, and the functional scores improve, both from the DASH and the Michigan Hand Questionnaire. Again, like I said, the numbers are not huge. So actually, it might just work. Actually, so this is a patient with the device applied. It is working great. So she's quite happy. Already got good motion, tolerating it quite well. And then the next video just shows the patient once the implant has been removed, the wounds have healed, and the patient, if I'm aware for it, is quite happy with the outcome. I think some of the x-rays you see are from hers as well.
She's already moving really well.
Yeah, so tolerated quite well. So like I said, I haven't had much exposure to this, but it's an option that maybe should be discussed with patients. So now I think we're kind of then on to the post-surgical hand therapy. So I wonder if we just pause there a second there, Michael. And as we saw some questions, I don't know if we've missed any of the questions. There's one just popped up about ice or heat management. For pre-op therapy, and Fiona, from your experience, I think you did mention some support from regards to splints which provide heat.
Yeah, so it is really patient dependent. Ice generally helps with any swelling. Sometimes if people have a more burning type pain, then I'd suggest a cold compression. Heat is better for getting that circulation going around a bit more, and it will relax any of the tight tissues. So if there's particularly stiff joints, we usually go for heat. So I'd usually say warm water, heat packs. Some patients like those paraffin wax baths as well, which they can purchase. So there's no right or wrong. It's more what's comfortable for them. I would just generally go by the rule that if it's because it's stiff, heat.
Yeah, great.
Yeah. I think I answered David's questions on the salvage procedure, as well as whether it's cemented or uncemented.
Yeah, so typically uncemented implants these days.
New messages at the bottom.
Any more new? But if it's an anti-inflammatory, would you still recommend heat? So typically for anti-inflammatory, you want to reduce that swelling, and probably cold therapy would be better.
Yeah, you could also use what we call contrast bathing, so getting a bowl of like ice cold water and a bowl of warm water, and then alternating between the both, which then causes that kind of dilation and contraction. So again, good for swelling as well. So nothing too hot generally.
Personal experience with periprosthetics?
No, I haven't had any periprosthetic fractures. But what's good to know is that obviously we do this under X-ray, and the key to doing that is to be just gentle with your reaming. You don't have to have cortical contact with your metacarpal stem for it to sit in place. There's been a paper that was presented at the International Hand Conference in London recently. They've got 5-year data showing that about 60 to 70% patients who had this had no cortical contact, and it showed no signs of loosening. So as long as you just realize that and not go for the fact that, oh, I need to make sure it's got cortical contact, you'll be fine.
So unlike a cemented, unlike an uncemented hip implant, you go for cortical contact. But in the thumb, like Shara does as well, I tend to undersize the implant in the metacarpal. That reduces the risk of periprosthetic fracture, and also gives you a chance, if there is some loosening, you can put a larger implant in and gain control later on if that.
And also when you're putting the implant in, as long as you push it in and it's stable, even if a bit of the base of the implant is sticking out, it doesn't really matter. There's a huge amount of space there, you're not going to impinge.
No, correct. So yeah, no experience of periprosthetic fractures. You can address them at the time. It's unusual to get a periprosthetic fracture around the metacarpal, more likely around the trapezium. If it's a fracture which creates an instability for the cup, you may have to convert, and that's one indication to convert to a trapeziectomy.
And I guess if you had a metacarpal fracture, then you would have to make the decision whether or not it compromised the stability and whether to convert to a trapezectomy as well.
Great. I think that's probably most of the questions at the moment. We're obviously very happy to answer more questions later on, but we'll hand over to Fiona on the post-surgical hand therapy side.
Because she makes all of these work.
She makes everything work, so absolutely. So critical, as all our physiotherapy colleagues are. So let's see if this remote works. It's just misbehaving a little bit, Mike, if we get you to control it. Thank you.
So these are just a quick couple of slides, actually, but post-surgery, obviously that immobilisation, they're casted usually for the first 2 weeks, as we've mentioned, so to get through that inflammatory phase as well, and that soft tissue healing. It does depend on which surgery they've had, whether we increase that or keep it around the 2 weeks before we start getting them moving. Again, like you've mentioned, whether it's stable, actually, if they've got post-op pain, also how they were functioning before, so how strong the hand was before. Like you mentioned, the gentleman earlier who he had one hand done and actually kept him still for a bit too long. He was ready to get moving on the second one. So again, a little bit patient dependent there as well. The pictures there are just the type of splint that I make. So that is a thumb and wrist thermoplastic splint, so keeping the top of the IP joint free. We tend to keep it in sort of a mid-palmar abducted position as much as we can. Again, if there's any contracted tissues, because I've had arthritis for a long time, a little bit more difficult. So in a comfortable functional range. So just quickly, just the time scale. So again, that first 2 to 4 weeks, so we really want to start getting them moving, and it can be started off gently, so that opposition again from to each finger. One thing that we've noticed is actually if the MCP joint gets too stiff, they actually end up putting too much force into that CMC joint. So again, really important to isolate and block that joint on its own. Scar massage, so mobilizing all that soft tissue, it can sort of create adhesions otherwise, reduce a bit of movement. Desensitization, if they've got any sensory changes post-op, we start getting that wrist moving as well, stop that from getting too weak. The next 4 to 6 weeks, so the splint, again, depending what they've had done, but generally continues. They want to be able to start using their hand for very light activities, and the movement that I would really encourage to not do at the moment is a combination of an adducted and flexed positions, that kind of tight adducted position, because of the risk of dislocating at the CMC joint. The splint that I've got there is known as a push splint. I showed one earlier that was like a prefabricated one. So they basically provide a gentle support to the CMC joint but allow everything else to move. So if they're starting those light activities, but we're a little bit conscious about any instabilities of the CMC, we could use that as well for those light ADLs. Towards the week 6, we start graded stability and a bit of strengthening. So we start with our isometric. So again, that nice tip to tip pinch. We could do an isometric against the first dorsal interosseous as well. Generally say that the thumb and wrist splint stays on for night time and those protective times where they might get knocked or something, just to keep, again, that joint in a nice stable position. And then we start progressing on to a bit more resistance, a bit more getting back into those normal everyday activities. I'd say around the week 6 is when we're doing those neuromuscular exercises again, normal movement control. Strengthening resistance at week 8, and then towards the 10 to 12 weeks is when we start really progressing to go back into full function. We know their strength is going to be pretty strong, but actually it's going to take time naturally for that strength to build. I'd say that we want to avoid that kind of sustained, really tight, pinched grip until about the 10 to 12 week point as well.
We did have a patient we did a Cartiva on, and she was playing tennis by week 6.
She was.
so this is personalised, let's say. This is the ideal time scale.
Yeah, she did have a splint
for
most of it, but yeah, she was doing pretty much most things. And again, because she was a very active person, coming out of the splints, and that she wanted to start moving, and it felt stable. Yeah.
Great. There's a question saying, is it contributing to your rheumatoid hands? I would say it's really down to the soft tissues. It depends on what's going on with the soft tissues. I personally would be a little bit apprehensive performing the Cartiva or the CMC joint replacement just because of the degree of laxity in the soft tissues. Probably more likely to offer a trapezectomy.
I agree. I think it's because of the risk of soft tissue problems, which means that it might be all right, but you increase the risk of developing problems. It also depends on how bad the rheumatoid arthritis is. But you need to have that discussion with them that if they start having active rheumatoid arthritis and synovitis, they're at risk of dislocating.
One thing with rheumatoid patients these days, rheumatoid patients are being so well treated that actually they are behaving more like osteoarthritis type patients. So
superimposed on rheumatoid arthritis.
On the rheumatoid arthritis. So it's a little bit of a tailored approach. If we find out good bone stock and minimal soft tissue laxity, then maybe.
Yeah. So if I've got a patient who's got osteoarthritis of the thumb on underlying rheumatoid arthritis, but she's got no features of local synovitis or problems, then I would have that conversation saying that it could be a problem, but I would be willing. But if it's someone who's got florid synovitis, always has pain in the soft tissues around the thumb, then probably not.
Yeah. Cool. So I think onto our last slide. So hopefully what we've provided is a kind of range, a spectrum of different treatment options tailored to the patient's condition severity, disease severity. We have a real emphasis on joint protection, strengthening and stability, activity modification at the early stages with very much non-surgical options, but having an ability to provide the simplest of surgical techniques such as CMC joint arthroscopy for patients with early stage arthritis, and progressing that onto the ultimate now, which is CMC joint replacement in patients with, let's say, grade 3 without the pan-trapezial arthritis. And as a team, we've built up enough experience to be able to offer patients confidently all these options to successfully kind of overcome the functional problems they've been experiencing and pain that have been experiencing. So this last kind of slide really kind of reflects that. So from the early stages, progressing on to the more advanced stages, tailored approach according to the patient needs and demands. And that concludes our presentation tonight. I wonder if there's any more questions. So actually, now that we're provided, there was one question about patients being able to return back to manual work. The patient that we performed, for example, the Cartiva option, he returned back to performing carpentry work. He was very happy. Trapezectomy patients tend to find a little bit of weakness in their grip, so they may struggle returning back to the high level manual work. But then that's where
the CMC
replacement comes in. In the past, the younger patients we used to offer, and we haven't touched upon this today, is a fusion of the CMC joint. Not commonly done. It's still an option that I do discuss with patients, and for the really heavy manual workers, that may be
one option.
The one option to
consider.
The implant, like we said, is lasting nearly 10 years in the majority of patients, but higher the demand, the greater the risk of loosening. That could happen and need for a revision.
Would adding PRP to joint distraction enhance the result of the distraction? Hard to say. I don't think there's any evidence for it, but again, there would be no harm doing that.
No, I suppose there's no loss. What we are achieving with the distraction is offloading the joint, as we mentioned, allowing some chondro protection, cartilage protection, and possibly some regeneration of the cartilage. The evidence for PRP and cartilage regeneration is small, so I think what it could provide is a better environment for recovery rather than directly regenerating cartilage. But that's sort of kind of theoretical and speculative.
Well, that's the idea for a paper there.
Potentially, yeah.